Neonatal care, Part 6, specific conditions. Seizures in the newborn, hypoglycemia, vomiting, and diarrhea. Seizures in the newborn strongly suggest the presence of a neurologic disorder. They're more common in newborns with low birth weight, as we've mentioned in the previous lecture. The following are often mistaken for seizures in the newborn: drowsiness or normal movements when the newborn is asleep, jitteriness, more commonly seen with hypoxic ischemic encephalopathy, hypocalcemia, hypoglycemia, and drug withdrawal, or gastroesophageal reflux and choking episodes. It's usually related to an underlying abnormality and may interfere with cardiopulmonary function, feeding, metabolic function, and prolonged seizures may cause brain injury. Types of seizures that may be seen in the newborn: a subtle seizure, which is characterized by eye deviation, blinking or fluttering, chewing, lip smacking, drooling, extremity movements, and apnea. Clonic seizures, which may be focal or multifocal, and tonic seizures, which may be focal or generalized. You may see persistent posturing of one limb, neck, or trunk, or horizontal eye deviation in tonic seizures. Spasms are a single brief 1 to 2 second sudden movement resembling a tic or a jerk. And a myoclonic seizure may be focal, multifocal, and generalized. Focal often involves flexion of the arms. Multifocal involves asynchronous twitching of multiple body parts. And generalized involves bilateral jerking with flexions of the arm and occasionally the legs. Causes of seizures: seizure onset up to 3 days after delivery are often caused by hypoxic ischemic encephalopathy, hypoglycemia, or other metabolic disorders. Hypoxic ischemic encephalopathy is the most common cause of seizures in newborns and usually occurs within 12 hours of birth. They're usually more severe during the first 48 to 72 hours of life. Metabolic abnormalities may include glucose issues, calcium issues, magnesium or other electrolytes, amino acids, organic acids, blood ammonia, and certain toxins. Hypoglycemia is another cause of neonatal seizures, with 2 major peaks of the incidence. The first occurs at 2 to 3 days after delivery and is most commonly seen in low birth weight newborns and in newborns of diabetic mothers. Late onset hypocalcemia may be seen in infants who consume cow's milk or synthetic formulas high in phosphorus. So quickly evaluate prenatal and birth history. Perform a careful physical exam. Obtain baseline vital signs and oxygen saturation readings, and provide additional oxygen, assisted ventilation, blood pressure evaluation, and IV access as necessary. If the blood glucose level is less than 40 milligrams per deciliter, give an IV bolus of 10% dextrose solution and recheck in 30 minutes. IV administration of dextrose often needs to be followed by a 10% dextrose infusion. Before giving an anticonvulsant medication, consult medical control. Benzodiazepines are commonly used to terminate neonatal seizures, but only with medical control approval. Monitor the respiratory status and oxygen saturation carefully. Maintain normal body temperature, and to keep the family informed as you transport the newborn. Hypoglycemia. The term hypoglycemia is going to be a blood glucose level of less than 45 milligrams per deciliter in term or preterm newborns, which is different than the adult levels. The adult levels are 60 milligrams per deciliter, but in the newborn is 45 milligrams per deciliter. Most newborns are asymptomatic until the glucose level falls below 20 milligrams per deciliter, and this may result in seizures or permanent brain damage. Risk factors of hypoglycemia: disorders of growth and maturity. Specific indicators: small for gestational age, smaller of the discordant twins with a weight difference of greater than 25%, large for gestational age, and low birth weight. Prematurity, less than 37 weeks of gestation, or less than 5.5 pounds, or 2.5 kilograms. Disorders of maternal glucose regulation, which include mothers with insulin-dependent diabetes, mothers with gestational diabetes, and a mother with morbid obesity. Neonatal conditions with disturbed oxidative metabolism, perinatal distress, a 5-minute APGAR score of less than 5, hypoxemia due to cardiac or lung disease, shock, hypoperfusion, sepsis, or cold stress, severe anemia, and you may see pallor in the absence of hypovolemia, or congenital anomalies and genetic disorders, visible anatomic deformities or abnormalities. Symptoms vary. You may see jitteriness, irritability, cyanosis, apnea, poor sucking or feeding, vomiting, limpness or floppiness, also known as hypotonia, irregular respirations, tachycardia, hypothermia, temperature instability, lethargy, twitching or seizures, or coma. Check blood glucose levels and evaluate vital signs. Manage hypoglycemia after establishing good oxygenation, ventilation, and circulation. Establish IV as necessary. Medical control may order dextrose solution if the newborn's blood glucose is less than 40 milligrams per deciliter, and it may be followed by an infusion of dextrose based on the newborn's gestational age. After we've treated, we'll recheck the blood glucose level in about 30 minutes. And as always, don't forget to maintain normal body temperature. Vomiting. Vomiting is common in newborns, and it ranges from spitting up to severe bloody or bilious projectile vomiting. Bilious and or bloody emesis needs medical treatment ASAP. Persistent vomiting is a warning sign and can cause excessive fluid loss, dehydration, electrolyte imbalances, and persistent or bilious vomiting may indicate an upper digestive tract obstruction or increased intracranial pressure. Vomitus with dark blood indicates gut bleeding and may be a sign of life-threatening illness. Vomitous aspiration may cause respiratory complications, including airway obstruction. Causes of vomiting also include esophageal atresia, and you may see newborns with excessive frothing soon after birth around the mouth area, possible choking when trying to feed, or GERD, and they may vomit either immediately or a few hours after feeding. In infants and young children, it presents as typical or atypical crying and or irritability, apnea and or bradycardia, poor appetite, vomiting, wheezing, stridor, weight loss or poor growth, also known as failure to thrive, hoarseness and or laryngitis. They may also experience a brief, resolved, unexplained event. Infantile hypertrophic pyloric stenosis may also cause vomiting, and in this case, the pylorus thickens and obstructs the end of the stomach. The stomach muscles contract forcibly to overcome the obstruction, and then you may see projectile vomiting, dehydration, malnutrition, or electrolyte changes. Intestinal malrotation is another cause. The sequence and the formation of the intestine is disrupted, and a spectrum of anatomic anomalies may result. An example would be the small bowel is found predominantly on the right side of the abdomen. This predisposes the infant to midgut volvulus and secondary obstruction of intestinal blood supply. Vomitus is bile-stained and possibly feculent if the obstruction is distal in the intestines. Morbidity and mortality from this cause have decreased significantly because of corrective surgical procedures. Congenital conditions such as intestinal atresia or intestinal stenosis may also cause vomiting. There's also a disease called Hirschsprung disease. The last colon segment fails to relax, causing mechanical obstruction, and the infant usually has a history of not passing meconium in the first 24 hours of life. With sudden, unexpected, and forceful vomiting, you may see asphyxia. It may also occur in conjunction with meningitis or hydrocephalus, or it may also be in conjunction with withdrawal symptoms. The stomach may be distended. Suspect infection if the newborn has a fever or a history of contact with people who are ill. You may also note temperature instability, apnea, bradycardia, abdominal tenderness or guarding, minimal or absent bowel sounds. Start with ABCs. You want to make sure that there's no aspiration occurring. Consider a nasogastric or orogastric tube. Do not administer antiemetics. The newborn may need fluid resuscitation of normal saline if dehydrated, and place the newborn on their side when transporting. Diarrhea. 5 or 6 stools per day is normal, especially when breastfeeding. Diarrhea represents a common cause for hospitalization in the neonatal and the pediatric populations, particularly when oral rehydration attempts fail and the patient becomes dehydrated. Most common causes or acute causes include viral infection or poisoning, and you may see additional symptoms including profuse sweating, lacrimation, hypersalivation, abdominal cramping, an intussusception, malrotation, increased intracranial pressure, and metabolic acidosis. Gastroenteritis is another cause, lactose intolerance, neonatal abstinence syndrome, thyrotoxicosis, or cystic fibrosis. Severe cases can cause dehydration and electrolyte imbalances with physical signs of ill general appearance, poor vital signs, capillary refill of greater than 2 seconds, dry mucous membranes, absent tears, weight loss, and low urine output. Estimate the number and the volume of loose stools. Decrease urinary output and degree of dehydration based on skin turgor, mucous membranes, or presence of sunken eyes. Maintain ABCs as well.